Hmm. Nimisha,
Yes, sir.
you watch the screen of Dr. Madhuri.
Please start, Nimisha.
Yes. A very warm evening to one and all gathered here. Welcome to ISI National Online PG Class Program. I welcome all esteemed faculties, senior consultants, and postgraduate students to today's class. Let us begin with a word of prayer and invoke blessings with Saraswati Vandana. Welcome back, everyone. I am Dr. Nimisha Mary Jose, screen coordinator for today's PG program. Today's class will be on anesthesia for renal transplant. I now request Professor Dr. Sukhminder Bhajwa, sir, Honorary Secretary, ISA National, to say a few words. Over to you, sir.
Thank you, Dr. Nimisha. And today's class is a very historic, being the last class of 2024. And we are ending the year with the three prominent, eminent GC members on the board. I can see them. I see a good smile coming from Dr. Ramakrishna Reddy's face. So Dr. Ramakrishna Reddy, Dr. Hina Chanwal, and Dr. Ashish Devan. Three GCs attending the class and one of the GCs presenting the class. So that shows the growth of the academics in the ISA National. And the topic is also such that which these people are doing. Dr. Hina and Dr. Bipin and the team is doing regularly the renal transplant at their centers. And when you are doing this type of surgery, the anesthesia management in these cases is always challenging. You are having two patients, one healthy patient and one patient with ESRD or any other renal pathology. So you are giving anesthesia to the two different entities at the same time. And you have to doing the PAC, you have to be together. The team has to be very, very, well oiled so that they can make no mistakes during transplantation. It is more than a normal surgery. I think it's beyond that also. And challenges are always there. Pathologies, challenges, clinical conundrums, so many things are there in these renal transplant surgery. Although it is a very, very common now, but still the transplant surgeries are very, very challenging from anesthesia side of view also. So let us today hear from the team, Dr. Bipin, Dr. Hina, and their third year postgraduates. So Nimisha, you can introduce them also so that we can go ahead with the class.
Thank you, sir. It is a great privilege to introduce our esteemed faculties for today, Professor Dr. Bipin Shah, sir, and Professor Dr. Hina Chanwal, ma'am. Professor Dr. Bipin Shah is a professor and head of the Department of Anesthesiology, GCS Medical College and Research Center, Ahmedabad, Gujarat. Sir has over 35 years of experience in teaching and practicing anesthesiology. He served as ex-HOD and senior consultant, Department of Cardiac Anesthesiology, UN Mehta Institute of Cardiology and Research Center, Ahmedabad. He is the co-editor of the book Clinical Cases in Anesthesiology, Long and Short Cases. Also, he is the author of the chapter on oxygen therapy in the book Essentials of COVID-19 for Anesthesiologists. I welcome you, sir. I welcome Dr. Hina Chanwal, ma'am. Madam is a professor, Department of Anesthesiology, Medical Superintendent of GCS Medical College and Hospital and Research Center, Ahmedabad, Gujarat. She is a senior faculty chairperson in various state, national, and international conferences. She served as secretary of ISA Ahmedabad City branch from 2017 to 2019 and also as a treasurer of ISA Gujarat State branch from 2021 to 24. Madam has organized more than 30 different workshops and has over 15 years of teaching experience in BLS, ACLS, and PALS. She is editorial board member of various anesthesia journals and also a reviewer at Walter Kluwer's. Madam is a chief editor of Essentials of COVID-19 for Anesthesiologists book. She has also served as a scientific secretary for ISACON 2021 National Conference. Madam has received various state awards like ISA Proficiency Award 2021, ISA Presidential Appreciation Awards 2021, ISA Jaipur Acute Pain Award 2022, and Gujarat State Women Award in 2024. I welcome you, ma'am. Before proceeding to today's class, I request all audience to stay muted for the entire duration of the talk. Any queries can be entered in the chat box and will be answered at the end of the class. All audiences are requested to keep their videos off. I now request Professor Dr. Bipin Shah sir and Professor Dr. Hina Chanwal ma'am to introduce their student and start today's session. Over to you, ma'am and sir. Thank you.
Hello. Yeah, good evening, Honorary Secretary, ISA National, Dr. Sukhvinder Singh Bajwa, Dr. Madhuri Madam, Dr. Riddhima Sharma, Dr. Nimisha. I would like to introduce my student, Dr. Ayushi Singh. Currently, she is pursuing a third-year PG residency at our institute, GCS Medical College, Hospital and the Research Center, Ahmedabad, Gujarat. She has done her undergraduation from the GMERS Medical College, Sola, Ahmedabad. She has completed her schooling from the Oman, and she has done her paper presentation at the ISACON Gujarat State Level Conference 2023, and she has presented the poster presentation at the Joint International Conference of the Cardiology as well. She has been a part of the 5 publications, original article. Her article on the opioid-free anesthesia also got featured in the Vapor News Bulletin of the Indian Society of Anesthesiologists. She is trained in the BLS and the ACLS courses. She has been a part of our Institute's Kyphoscoliosis International team and the renal transplantation team as well. So over to you, Ayushi.
Good evening, everyone. So I'm presenting my case on the anesthetic management of renal transplant surgery in end-stage renal disease. So my case is of a 27-year-old male with 80 kg weight who has anuria since 3 years and is a known case of chronic kidney disease who is biopsy proven post-infective glomerulonephritis, and he is on maintenance hemodialysis since last 3 years. He is posted for renal transplant surgery.
So, Dr. Ayushi, can you tell us what is the function of kidney?
So, ma'am, function of kidney can be easily remembered with a mnemonic, which is a wet bed, which stands for acid-base balance, water and electrolyte balance, toxin removal, blood pressure control, and erythropoietin, and vitamin D metabolism.
Okay. And can you classify the CKD, chronic kidney disease?
So, ma'am, CKD is a progressive, irreversible decline in renal function for more than 3 months, and in which it causes GFR to reduce for below 60 ml per minute per 1.70 meter square.
Okay. And how do you measure the glomerular filtration rate, Ayushi?
So, ma'am, we estimate the GFR from the Krakow-Ganloff formula, which is 140 minus age into weight in males, and we multiply it with 0.85 in females, divided by 72 into the serum creatinine value of the patient.
Okay, good. And what could be the pathophysiology of the CKD patient?
So, ma'am, the pathophysiology, as I have shown in this slide, that there is a decrease in number of nephrons, which then due to adaptive hyperfiltration of the glomerulus, like in stage 1, we see that the GFR is more than 90. It is either normal or more. Then there is an increased glomerular permeability, which leads to increase in filtration of proteins and macroglobulins, leading to proteinuria. That's why even we see that these patients have proteinuria like +1 or +2. Then again, which leads to dyslipidemia. Then there is increased RAS leading to hypertension. That's why most of the patients of CKD are on antihypertensives. And there is then again damage to the nephrons and nephrotoxic inflammation, and there is remodeling at a cellular level, which leads to decrease in GFR, decrease in urine output, and all other systemic complications seen in the case of CKD.
Okay. And what could be the different causes of the CKD?
Some causes of the CKD, the most common cause is diabetes, mellitus, followed by glomerulopathies, systemic hypertension, tubulointerstitial diseases, or it can be obstructive uropathy, hereditary, or even lupus, systemic lupus, SLEs.
Okay, you can go ahead.
Yes. So, in history of present illness, the patient was relatively asymptomatic before 4 years. Then he gradually developed decreased urine output, hematuria, and facial puffiness. He was diagnosed with CKD and was on medical management. Renal biopsy done, which showed post-infective glomerular nephritis. Eventually, he developed anuria and was started on MHD. Frequency of MHD is 3 per week, and last dialysis was 4 days ago.
So what is the treatment of CKD, Ayushi?
So, ma'am, treatment of CKD can be initially, like in this case, we see it can be medical management. Like we can use diuretics, soda bicarbonate to manage CKD. But as the disease progresses, we have to go for dialysis or renal transplant. Now, dialysis has a poor survival rate, poor quality of life, and is much costly. And renal transplant has a better survival rate, that is around 70%, and with better quality of life. So this person, our patient who has CKD since now more than 3 years and is on dialysis since 3 years, has been posted for a renal transplant.
Go ahead.
So he is known case of hypertension since last 4 years, and he has no history of diabetes, coronary artery disease, cerebrovascular accident, recurrent respiratory tract infections. In treatment history, he is currently on tablet nifedipine 20 mg TDS, tablet clonidine 100 microgram TDS, tablet soda bicarbonate 500 mg OD, tablet calcitriol 0.25 microgram OD, injection erythropoietin 4000 units weekly once. And in surgical history, he has a AV fistula on left forearm, which was done under local anesthesia.
So what are the hematological abnormalities that has been seen in the CKD patient?
Ma'am, in hematological abnormalities, these patients have normocytic normochromic anemia, which is mainly due to decrease in erythropoietin production. That's why even our patient is on erythropoietin, and there is a decrease in RBC lifespan as well. And there is also coagulopathies as well seen, and there is a functional decrease in the quality of the platelets. So even they have coagulation abnormalities present.
Okay. I should, since your patient is on the tablet calcitriol 0.25 microgram OD, so this is the supplemental therapy. So how is the serum calcium level affected in the CKD patient?
So, ma'am, in CKD, due to decreased renal function or mass, there is decreased renal excretion of phosphorus, and there is decreased conversion of vitamin D to its active form. So now it leads to increase in serum phosphorus and decrease in serum calcium, which leads to increase in parathyroid hormone, leading to secondary hyperparathyroidism, which increases the bone turnover. Now, this also increases the osteoblast activity, leading to, we can say, renal osteodystrophy. So, these patients are also prone for fractures. And that is why even we need to take care about their positioning while we are handling them in OT. Ours is a young patient, but we have old patients as well. And otherwise, also, they have weakness due to this.
So most of the CKD patients, we are addressing them in the preoperative area with the AV fistula. So what is this AV fistula?
Ma'am, AV fistula is a surgically created procedure in which the artery and the veins are connected, and they are basically to create a stronger vessel. The vein is very thin initially, like when we used to draw bloods, but that cannot be used for dialysis because it's very high pressure. So the fistula is created between artery and vein, mostly between radial artery and cephalic vein or brachial artery and basilic vein. So then eventually epithelialization occurs and the vein becomes strong, and it takes around 4 to 8 weeks for it to establish its function, and then it can be used for dialysis. It's like making a high pressure blood from artery constantly goes to the low pressure flow of the
Okay.
veins, which makes it thick.
Okay. Yes, go ahead.
So I'm summarizing the part of the general examination. So patient is conscious, oriented, and coherent. He is thin built and moderately nourished. He has pallor, no icterus, cyanosis, clubbing, or edema. He has a working AV fistula over the right forearm. Pulse is 98 per minute, regular in rhythm, normal in character and volume. No radiofemoral delay. Thrill present over AV fistula. BP is 146 by 92 mmHg, measured in sitting position from, uh, I'm sorry, it should be left upper arm since right arm has the fistula. Respiratory rate is 16 per minute, METs is 4, SpO2 is 99% on room air. Airway examination shows 3-finger mouth opening, modified Mallampati grade 2 with no loose tooth, neck movements are normal, spine is normal and is in midline. RS-wise, bilateral normal vesicular breath sounds are heard. S1, S2 is heard in CVS with no murmurs. JVP is not elevated. CNS, he has no focal neurological deficits. Higher mental functions are normal. Abdomen, there are no scars, sinuses, dilated veins, and the abdomen soft, non-tender. Umbilicus is in midline with no organomegaly. Normal bowel sounds are present.
So what are the systemic abnormalities were expected in the CKD patient?
So, ma'am, in systemic abnormalities, we can see neurologic, there are fatigue, headache, sleep disturbances, encephalopathy. This mainly due to increase in urea levels due to uremic encephalopathy can happen. There is ocular, there is hypertensive retinopathy. There can be pulmonary edema, uremic pleuritis, or pneumonia. These RS manifestations are due to volume overload. Then there can be pleuritis, ecchymosis, dry scaly skin. Musculoskeletal again can because of this calcium imbalance and vitamin D, hyperparathyroidism, osteoarthritis, fibrosa, osteomalacia. Then there can be peripheral neuropathies. Also, mostly since the most common cause is diabetes, so all these features can also again peripheral neuropathies can be exacerbated in those cases. Then in hematological, like I had explained before, cause for anemia, bleeding, infection. Then metabolic, there can be hyperlipidemia. In endocrine, there is thyroid abnormalities and hyperparathyroidism. In gastrointestinal, there is again anorexia, nausea, vomiting. These patients are definitely like our patient is thin built and poorly nourished. And in cardiovascular, again, like our patient is hypertensive. They can have concurrent coronary artery disease or peripheral artery disease. And they can also have anxiety or depression. That is the psychological manifestation.
Okay, very good. Go ahead.
So in investigations, his blood HB level is 10.5. The abnormalities I'm highlighting here, creatinine is again raised 9.96. His last dialysis was around 4 days ago. His potassium level is 5.82. Blood group is B positive. Rest reports are pretty much in the normal range. And since he is a renal transplant recipient, for the matching process, we have done ABO blood grouping with the donor, HLA tissue matching, and lymphocyte cross match, which is T cells and of the recipient serum and donor's lymphocyte.
Dr. Ayush, how actually the electrolytes get affected in the CKD patient?
So, ma'am, like we see in our case, potassium is raised. So, the most common abnormality seen is hyperkalemia. That is due to potassium cannot be excreted out due to from the distal tubules as the kidney is not functioning, and that also leads to acidosis as more as H plus ions move in. Now, for every you can say 0.1 milli equivalent of increase in potassium, there is 0.1 unit reduction in pH. So that's why mostly these patients have metabolic acidosis due to this reason. Coming to sodium, now mostly these patients are volume overloaded, and due to which mostly they have hyponatremia, and in some cases even hypernatremia can be seen. And even in rare cases we see hypernatremia, mostly it's hyponatremia. And coming to other electrolytes like magnesium, there is decrease in magnesium clearance, and which leads to decrease in muscle, which leads to muscle weakness. And hence in our anesthesia, when we give neuromuscular blocking agents, so their effect can be potentiated due to that, due to hypermagnesemia, as magnesium is not cleared.
So, how will you prepare these CKD patients pre-operatively?
So, ma'am, like our patient pre-operatively, we will optimize the patient by getting adequate blood pressure control. Like our patient's blood pressure is pretty much good. Then correcting the electrolyte abnormalities, like potassium is high in our patient. And then correcting coagulopathies and correction of fluid overload, if any, doing dialysis on time. And if HB is very less, then we advise transfusion. Otherwise, we avoid, because we don't want to sensitize the recipient.
Okay, good. Go ahead.
So now coming to donor. So the donor is the mother. She is a 49-year-old female with 76 kg weight. She has no comorbidities, no past surgical history, allergies, or blood transfusion. She is a clear ASA grade 1. Her all investigations are normal. She is vitally completely stable, and all systemic examinations are normal.
So, Ayushi, now what is the role of anesthesiologist in the renal transplant?
Sir, the role of anesthesiologist is for both the recipient and the donor. So we have to optimize the recipient very well, and even the donor. And also, that is in the case of when we are going for a live transplant. In the case of diseased, that is cadaveric transplant, there is a role of anesthesiologist in declaring brain death as well. They are part of the team. And there is the management of the donor in ICU and in organ procurement, for that the organs procured are of good quality and that they're optimally functioning.
Now, what is where the donor kidney is transplanted in the recipient, and which kidney we usually prefer and why?
So, sir, from the donor, we take the left kidney mainly because the left renal vessels are longer, and it's also a little up and easier to access. So that when we are doing anastomosis, the veins are of adequate size. So from the donor, we take from the left kidney. And in the recipient, we transplant it in the right iliac fossa. And anastomosis is done with the iliac vessels.
Okay, there is one question.
Yes.
Yeah, you just put that slide. So, which type of donor is most commonly used for the renal transplantation? So, you just write down in the chat box.
The audience are answering, I believe.
Can we move to next? I think so.
1 second. Ayushi, just
Yeah.
read the what are the alternative options? Give them some time, yeah.
Okay, so the alternatives are A, that is disease donor, B, that is living related donor, C, that is living unrelated donor, and D, that is cadaveric donor.
Yeah, there is a lot. Many people have opted for B and some for D also. So can you tell the correct answer?
So, ma'am, the most commonly
Yeah.
used is living related donor. Option B is the right answer.
Please go
Oh,
ahead.
Okay, now what are the anesthetic principles in the management of living donor?
So, sir, the anesthetic principles for living donor is mainly that pre-operatively we need to understand that donor is a healthy individual. He or she is not a patient. So, any adverse event, if anything happens to the donor, it is a huge setback for the entire transplant program. It is a huge failure. So, we need to adequately pre-operatively optimize uh, and assess the donor, and we have to ensure that the donor is in sound mind and body. And for that, at our institute, we do psychiatry reference to ensure that, and even that is for medical legal basis, we do gynec reference if it is a female, and any other references to ensure that the donor is healthy and nothing happens to the donor. And then coming to the intraoperative part, we always need to ensure that there is no morbidity or mortality. We, with ASA standard routine monitoring, we monitor, and we use strict aseptic precautions while handling the donor, and we need to give them careful positioning. There should be no injuries. We give balanced general anesthesia, and we maintain a good intravascular volume and renal blood flow so that nothing happens to the donor's kidneys, and also that the kidney which is procured is of good quality. We ensure that the urine output is more than 2 ml per kg per hour, and for that we use mannitol 20%, 0.5 gram per kg generally, before they clamp the vessels to maintain the perfusion. And in post-operative period, we ensure there is adequate pain relief throughout, even intraoperative, and ensure early mobilization, less hospitalization, and early discharge. We need to understand that this donor is going to tell others also in the community about his or her experience. So if there is pain or anything adverse which happens to the donor, then even others might not get motivated to come for transplant.
Yeah. So, what are the type of nephrectomy in living donors?
So, sir, the type of nephrectomy is open or lap. We generally do lap nephrectomy because laparoscopy provides easy early mobilization and all the benefits of lap surgeries. But again, where the main important part of lap nephrectomy is that the position is steep head low and in kidney position. So we need to ensure, and there is pneumoperitoneum created, and again they access it retroperitoneally, or multiple type of accesses are there. So we need to ensure that our anesthesia is well balanced. At our institute, we use all ASA monitoring. Apart from that, we even use TOF monitors so that we can give our muscle relaxants accordingly, so that they are extubated on time, there is no delayed extubation, and we maintain good depth of anesthesia, and that's why we give general anesthesia, so that they have no discomfort while laparoscopic nephrectomy is being performed.
So now we have procured the kidney. Before we move further with the perfusing the kidney, let us go back to the recipient. Tell us, what will you do on the morning of the surgery before you take the recipient in the OT?
Okay, so we will ensure that the dialysis is done within 24 to 36 hours of surgery. At our institute, it's mostly by 24 hours of surgery. And since the dialysis is done, so we'll see whether how much negative they have done, how many kgs they have removed, and was it heparinized or not. And once the dialysis is done, we check the weight of the patient. We repeat serum electrolytes, coagulation profile, ECG, and chest X-ray. And we always maintain strict aseptic precautions throughout. And we continue the medications till the day of surgery, such as antihypertensive, anti-anginal, anticonvulsant, antiarrhythmics. Antihypertensives, which it's not a strict protocol that we continue, because we check the morning BP first. If it is very high, then only we give. Otherwise, we avoid, because then during induction, the BP can fall. So according to the morning BP, we assess whether we have to give or not. Then aspiration prophylaxis is done by H2 blockers, proton pump inhibitors, and metoclopramide. We take care of the AV fistula. We check its patency by palpation, cover with Gamterol. We ensure that there is no IV line or BP cuff. And we start immunosuppressants, that is induction therapy, with anti-thymocyte globulin. on
When
the morning of surgery.
yeah, and when it should be completed.
So ATG, we start like 2-3 hours before we take the patient to OT, and we finish it once the recipient's kidney has been anastomosed. The donor kidney has been anastomosed with the recipient's vessels, and we remove the clamp. So before, just when the perfusion starts, by then the ATG is generally completed.
And usually at what times we take a recipient inside the OT and start anesthesia?
So first we start with the donor, and as we know, even before the donor kidney is getting dissected, depending upon the time, we start with the recipient because we want to make that bed and keep it ready so that once the kidney is out of the donor, we need to reduce the ischemia time so that as soon as the kidney is out of the donor, we just perfuse it so that the warm ischemia is less and perfuse it and the cold ischemia is decreased if we just keep the bed ready and then we just put the kidney in the bed. So if the bed is ready at a good time, we can reduce cold ischemia time, which will lead to good graft function later on.
Why should we focus on the aspiration prophylaxis, particularly in these patients?
So, in patients of CKD, there is gastroparesis, and even due to diabetes, like I said, it's a common cause. There is again gastroparesis. So these patients are can be even after 12 hours NBM or 10 hours NBM due to gastroparesis, they might not be NBM. So that is why we need to focus on aspiration prophylaxis. And for that, we give H2 blockers, PPI, and metoclopramide. Metoclopramide because it does gastric emptying very fast. So because of that, even we even prefer RSI at times because of the same reason of gastroparesis.
Now, what is the role of ATG?
So, sir, ATG is an antibody prepared from rabbits or horses which have been hyperimmunized. And it is an immunoglobulin which is used to manage cellular rejection in cases of transplant. So, it acts as an immunosuppressive therapy, and generally it is used as a induction therapy. Its mechanism basically includes that it binds to T surface antigens and uh, it it decreases cell destruction through antibody dependent cell mediated cytotoxicity, and it inhibits T cell activation, and it also causes immunomodulation, and it has anti-inflammatory effects a bit. So that's why we use it, and generally we use it at a dose of 1.5 mg per kg, and it comes as a powder in a vial. So we reconstitute it with sterile measures on the morning of surgery and start it at such rate via infusion pump that it gets over when the clamps have been removed after anastomosis.
Very good. Now, let us take the recipient to OR. Tell us about the intraoperative management.
Right, sir. So, intraoperatively, when the recipient comes to the OR first, we ensure that everything is completely sterile. We ourselves even wear ETO scrubs, and everything is sterile, everything is ETO, so that there is no scope of any infection because the recipient is immunocompromised. We have already started on immunosuppressants. Then, with sterile everything, we attach all monitors, and we generally at our institute, we have a combined general plus epidural anesthesia. That's what we give. So
Why
first
why we are
sorry, sir.
giving epidural here? Is there
Sir,
any
because
role of epidural intraoperatively?
uh, sir, epidural anesthesia has important role for pain relief intraoperatively and postoperatively, but in this case mainly it is for postoperatively because and we also give doses intraoperatively depending upon the hemodynamics. And we generally use morphine, which is very good, and it provides postoperatively more than if one dose, we just give 1 mg, it provides more than 24 hours pain relief in the patients. And they are very comfortable, which leads to early mobility and even early discharge. As they are pain free, even their respiration is good, and due to pain relief, they feel much better. And even their entire respiration, everything is good because of that. So we always put epidural first, and then we induce the patient, and then we secure a central line because we give CVP guided fluid. And then routine NIBP, ECG, SpO2, EtCO2, temperature probe. We keep the patient warm, and urine bag with a urometer. And in high risk patients, we have invasive BP monitoring. And we have in very high risk, we even do cardiac monitoring. But we always try to go non-invasive more. If it is not indicated, we don't take IBP or advanced cardiac monitorings. Um, that is about the monitoring part. Then moving to induction agents, we use thiopentone, propofol, etomidate, or fentanyl, morphine, remifentanil, elfentanil, sufentanil if available. Our setup don't use them much. And in neuromuscular blocking agents, we use succinylcholine, atracurium, cisatracurium, and inhalational agent, that is isoflurane, desflurane, or sevoflurane, anything.
Can you use succinylcholine for the intubation?
We can use, depending upon the potassium levels of the patient. And if we are doing RSI, then accordingly, and according to difficult intubation. If it is not a difficult intubation and easy back and months, we can induce with atracurium as well, which we do. We try to avoid succinylcholine.
Okay. List of some nephrotoxic drug. There is one question.
Yes, sir. So it's a good mnemonic which I found, that is Carnival Camp, to remember the common nephrotoxic medication. So calcineurin inhibitors are there, ACE inhibitors, ARB, radio contrast, NSAIDs, ifosfamide, vancomycin, aminoglycoside, lithium, and cisplatin, amphotericin, methotrexate, penicillin. These are all nephrotoxic medications.
Okay. Then question regarding the hyperkalemia. So, which of the following should be avoided in the CKD patients due to risk of hyperkalemia?
So
First,
the options are, yes.
B is rocuronium, C is cisatracurium, D is atracurium.
I request all audiences to type in chat box as fast as possible. So most of the answers are option A, succinylcholine, sir.
Yeah, right.
That is the right answer. So that is why we avoided. If it is not a difficult airway, we induce an ATRA routinely at our setup.
How do you perfuse the procured kidney from the donor, and what are the solutions used?
So, sir, once the kidney is out of the donor, and we keep it in a container, sterile container, which has ice slush. But we don't keep it in direct contact with the ice. The temperature is maintained around 0 to 4 degrees Celsius. At our setup, we use HTK, which is histidine, tryptophan, ketoglutarate, where histidine acts as a buffer, tryptophan is an antioxidant and a membrane stabilizer, and alpha-ketoglutarate is a separate substrate for anaerobic metabolism. There is another solution, which is University of Wisconsin. Here, the osmotic agent is lactobionate raffinose. HES is used as colloid and scavenges glutathione and allopurinol. Adenosine is the energy source. There's another one which is urocolins, but it is rarely used. And these solutions, cold perfusion solutions, they suppress the metabolism, and they keep the kidney
So ultimately, the metabolic requirement we cannot stop that metabolic requirement or metabolism, but we want to make it a slow down. So by all these means, we want to try to make slow down the process, and the requirement and metabolic toxins are
keeps, and it improves its storing condition. It even scavenges.
Yeah. Then what are the different ischemia time?
Yes, sir. I think My screen is visible.
No.
I have to
Aishi, can you once again screen share?
Yes, ma'am. Is it visible?
Yeah,
It
it's
is
visible.
visible.
Yeah.
So the ischemia times are warm ischemia time, which is once we clamp the arteries of the donor and till we start perfusing it and it becomes cold, like it changes its color. So that is warm ischemia time. So during this time, the kidney is very metabolically active. So it needs to be as less as possible. So what we do as we clamp, we try to retrieve it the fastest out of the donor and start the perfusion quickly and to achieve that cool so that it's cold at the right time, because once it's cool we can't stop the metabolism, but at least the metabolism has been reduced. And from that time, once it's cool, like you can see that it has changed its color from red, from little, it has become little pinkish kind of. And then the cold ischemia time starts from where it has become a bit cold till we remove it and we put it in the bed and it starts becoming warm. So generally what happens, like sir had asked me before, that when do you take the recipient? If the bed is not ready by then, or due to any other reason in a living donor, if the cold ischemia time has increased a lot, then the outcomes will get affected. So we need to decrease this cold ischemia time as much as possible. And then starts the rewarm ischemia time. That is once we have removed it from the cool ice slush and put it in the bed and we are anastomosing it. So till the anastomosis is completed, that is the rewarm ischemia time. And once the anastomosis starts, then we'll see how it works. Until then, our ATG also should have been completed.
So what it should be? What ideal warm ischemia time? How much it should be?
It all these times should be as less as possible, but we allow 3 to 5 minutes of warm ischemia and 20 to 30 minutes of cold ischemia for living donor. And for deceased, the cold ischemia time is very long for deceased donor because that is a completely different thing. And again, rewarm ischemia is again a few minutes, like how warm ischemia is.
Okay, I see. Now tell us something about the ischemia reperfusion injury.
Okay. So, like I said, that when we remove the kidney from the donor, it's a metabolically active organ. So what happens now due to what we are trying to do is reduce this reperfusion injury. Now, what is reperfusion injury is what happens is when we take the donor kidney and put it in cold um, perfusion solution, the metabolism is not stopped. It is still going on. That is why I said that cold ischemia time needs to reduce. Why is that? Because even though the metabolism is slow, but it is there is hypoxia, there is hypothermia, which leads to generation of reactive oxygen species and all other inflammatory mediators. And then those all get collected in that kidney. Now, once we take the kidney out, our rewarm ischemia time starts, and then we anastomose it. And once the anastomosis is complete, when the perfusion begins, all these inflammatory mediators now go into the system, leading to ischemia reperfusion injury, which again, like I said, can be decreased by decreasing cold ischemia time, perfusing it well, and all this can reduce it. And yes, with our immunosuppressant agents.
What will be your hemodynamic goals on the reperfusion?
So once the donor kidney has been transplanted into the recipient, then our hemodynamic goals of perfusion will be to maintain CVP between 10 to 15 mmHg, SBP more than 130 mmHg, mean arterial pressure more than 90 mmHg, and if we have done it in PCWP 12 to 18 mmHg. What happens is before the kidney is transplanted, we give fluids very restricted. We measure the CVP because anyhow we have just the patient has been dialyzed the patient, so we don't want to overload because that time if we give fluid, patient will be overloaded. But once the kidney is anastomosis has been done, clamps have been removed, we will see that how kidney is functioning, how urine is coming. So these are our goals at that time once the clamps have been removed. So once the clamps have been removed, or even just before the clamps have been removed, we give mannitol 20%, 0.5 gram per kg, and furosemide 2 mg per kg, so that the kidney is flushed and it's working well.
And what fluids you will use?
So we use NS or plasma light in crystalloids, and we can use RS, but we generally use NS and plasma light in crystalloids.
So how much will be the urine output after the grafting or immediately after the anastomosis?
So we have seen that immediately after anastomosis, the kidney is functioning very much. It's around 1 liter per hour roughly. It's like a continuous dribbling of urine in a stream, like a water tap has been opened.
Then what is the role of mannitol here?
So, sir, mannitol is a osmotic diuretic. What it does, it um, perfuses the kidney. It sensitizes to prostaglandins, and it decreases excessive tissue and intravascular fluid if there is any overload. There is a local release of prostaglandins, and it improves renal blood flow, and it also acts as a free radical scavenger, and it prevents ATN, which is a complication as well. So mannitol has a big role in a case of recipient. In donor, it is to maintain to flush it off, kind of, to maintain good perfusion.
If blood loss is there, usually we taking care about that there should not be any blood loss. But if blood loss is there and if we have to give a PCV, then what the care you will going to take?
So, first, like you said, so that we'll avoid any need for transfusion. But if it is still there, there's blood loss and CAP is not there, and we have to transfuse. So we will use. So that's why in pre-op itself we keep irradiated blood preserved, and we use even leukocyte filters, so that there is less antigen or reaction or any kind of reaction, because again our recipient is immunocompromised. So that's why we use irradiated blood with leukocyte filters.
Now there is a question: why is intraoperative urine output of recipient monitored closely during the renal transplant surgery? A, it helps to evaluate the cardiac output. It provides an indirect assessment of graft function after reperfusion. It determines the need for intraoperative dialysis. It provides an assessment of electrolyte disturbances. So please answer.
Audience, please enter your answers in chat box. Sir, most of them have answered option B.
Yeah, yes, right. Because if graft function is very good, then after the reperfusion, then urine output is very good and we can see the dribbling. Then again, one question: which of the following strategies can reduce the ischemia reperfusion injury in the renal transplantation? Minimizing cold and warm ischemia times, using higher concentration of preservating solution, prolonging cold ischemia time to allow the tissue recovery, or avoiding intraoperative vasopressors during graft perfusion.
Sir, we have a majority of option A answers.
Yeah, minimizing cold and warm ischemia time, it's a correct answer. How will you manage the recipient post-operatively, Ayushi?
Sir, post-operatively, we shift the recipient in isolation in a HDU, and we extubate the recipient, and we ensure there is no pain. So even before shifting, at times we ask the patient and see the hemodynamics and give via epidural a dose of morphine, still monitor intraoperatively if everything is stable. We shift the patient to HDU. We check for properly for input-output charting,
Why?
and
How will you replace that fluid? Because now urine output is a very huge amount, no?
yes. So since we have put the CVP, we again monitor the CVP in HDU and we maintain it between 10 to 15 Hg. So how we manage the fluid is we use Previa-Ras urine output, which is, I said again, in very high quantity, plus 30 ml of 0.45% NS and 5% dextrose, which 20 ml of soda bicam. So this is how we manage the fluid replacement post-operatively. And along with that, for post-operative pain relief, we have IV opioids or PCAs or epidural narcotics, and the patient is again continued on various immunosuppressants like tacrolimus or MMF, depending upon what the nephrologist have started in the maintenance phase of the immunosuppressants.
So, what are the immunosuppressants we are using?
So we use tacrolimus, microfilm methylfolate, and ATG, even steroids, methylprednisolone. So all these we use, and we monitor the tacrolimus levels very carefully.
Okay. If you have any time allergic reactions to all these immunosuppressants, how will you treat and how you will tackle the situation?
So sir, if there is any allergic reaction like anaphylaxis or something, the patient is already on steroids, we'll give histamines. If there is very severe, we'll then manage the hemodynamics, or airway if is compromised, then we'll manage accordingly. So however are the signs, so we'll manage accordingly. Like airway should not get compromised, hemodynamics should not get fluctuated. Mainly, also, especially there should be no hypotension, because now this transplant kidney is perfusion dependent. So anytime any hypotension or anything happens, then it can lead to graft failure.
And usually, we have seen that in the CRF patient, platelets dysfunctions are there.
Yes, sir.
Still, we are putting epidural catheter. So, what care we should take and what the pre-operative measures we take?
So we have now this dysfunction of platelet is mainly functional, like you said. It's not the number. So even if we do CBC, platelet count might be normal. So what we ensure that even while yeah, so what we do is that a senior performs it in strict aseptic conditions, and we get it at one go. There should not be any bloody tap. We palpate the area very well, and some senior performs it with that one go. We should get it, and we fix it properly, and we remove it at post-op day 3. Early we remove, because again we use morphine, so by post-op day 2 3 easily we remove it and the patient is very comfortable. Same is for, I believe, intubation that a senior does, because it needs to be again very strict aseptically. Even the oral flora shouldn't enter, so direct it should be in the trachea, the tube. So this is what we practice at our institute.
And if you want to use choline, at what level, or if serum potassium level, at what level you will use succinyl choline?
So if it is less than 5.5, we can use it safely. Otherwise, more than that, we avoid it. And at our setup, if the airway is easy, then we avoid it and we go with Atra itself.
Then which agent you will use?
We'll use atracurium and ventilate for 3 minutes, because we know that the airway is easy. So it's easy to bag and mask. So that's
Rocuronium?
yeah, we can use rocuronium as well, yes, for RSI, because again, it's good that we, like before, due to gastroparesis, we should use rocuronium. because it's again faster. So better alternative. So succinylcholine is rocuronium, definitely.
Yeah. And sometimes we had faced so many times there is a hypotension just after the induction.
Yes.
How will you manage?
So, first is we manage it with fluids because anyhow the patient is negative. They do 3 or 5, depending how much negative they have done, maintain the CVP. Now, if the hypotension is still sustained, then and there is no blood loss.
Yeah. And still, if with the fluid, after with the measurement with the CVP, if I think that I had enough preload is there, and but I cannot maintain the 90 mean arterial pressure, then what I should do?
With Thio or what?
Hello?
Aishi, I think your screen is stuck.
Yeah, audio is also lost. So usually at that time we use the noradrenaline. Hello, are you seeing?
Hello, Dr. Aishi. Can you hear us?
Are you seeing?
Yes, sir. I didn't get the question, sir. Can you please repeat, sir?
Yeah, with the fluid after maintaining the CVP, still I am not able to maintain the blood pressure. Then
Yes.
what the vasopressors you will use?
So, sir, we'll use norepinephrine, noradrenaline.
Yeah.
Even though at the risk of other things, we need to maintain the BP, it affects renal blood flow, whatever, but we have to start noradrenaline.
Now, how will you manage the recipient post-operatively? How will you replace the fluid post-operatively? And what are the post-operative complications?
So, sir, post-operative complications can be divided into anesthesia-related, surgical, or medical. So, in anesthesia-related, there can be delayed recovery, pulmonary edema, cardiac arrhythmias, hyper or hypotension. So, to ensure that there is no delayed recovery in both, we use TOF monitor, and we can use advanced monitoring as well, BIS and other thing. And delayed recovery can be due to other things as well. So, we try to avoid it. Pulmonary edema can be because of fluid overloading, which we avoid before the kidney is transplanted, because that time it's like we have dialyzed the patient, made it negative after so much, and if we overload, then that can cause it. And like I said, we have to avoid hyper and hypotension. And so these are the anesthesia related complications which can occur post-operatively. And surgical can be vascular, that is, there's an anastomosis leak or arterial venous thrombosis, urinary leak or obstruction, like we say if urine is not coming. And then there is medical, which is rejection or ATN.
Okay, I think that over from our side.
Good evening, sir. There are a few queries from the audience, sir.
Yeah.
Shall we go through it,
Okay.
sir?
Yeah.
Okay.
So, sir, so there is a question: do you use other immunosuppressants other than ATG, and when do you start?
That question has been answered by the IUC, tacrolimus and
Yes, sir.
steroids and everything.
Yes, and Dr. Sadik has asked what is the sequence of clamping vessels during anastomosis in recipient versus donor and its significance, sir?
What, madam?
Dr. Sadik has a question. What is the sequence of clamping of vessels during anastomosis in recipient versus donor and its significance?
Yeah. In the donor, they lastly clamps the artery because the supply will be with the artery. So first they uh, uh, dissect everything around that, and last clamp will be the artery, and they remove that. And when they put in the recipient, first they put anastomosis with the artery, and then they do the vein. That will be the sequence.
Sure, sir. Thank you, sir. Sir, then Dr. Rekha Solanki has asked alternate regional anesthesia techniques other than epidural analgesia for transplant recipient patients.
So apart from epidural, we have the sonography machine, so that we can go for the thoracic paravertebral block, or we can go for the TAP block, rectus spiny block. So these are the different advanced modalities for the pain relief is available nowadays.
Yes, sir. And Dr. Muthukumar has asked, epidural can cause hypotension post-transplant. So what drugs do you prefer in an epidural infusion for post-op analgesia?
Sir, in our center, we are using only morphine 1 to 2 milligram diluted in 10 ml, and it doesn't cause any cardiovascular impact on morphine. If we use local anesthetic agents, then it might create a hypotension. But here we don't face any problem, and effect is very long. I think more than 12 to 24 hours we see the effect. And what we see, all the disadvantages of the local anesthetics, here in the morphine we don't see anything.
Yes, sir. Thank you, sir. Sir, Dr. Muthukumar Rajagopal has asked, can we do a platelet function analysis before performing an epidural, sir?
Yeah, but
Is there any role in that, sir?
Yeah, platelet functions we can see routinely with the bleeding time and platelet numbers, but adequacy of that usually we don't see, and we are not face a problem.
Yes, sir. Yes, sir. And sir, Dr. Prerna Thakur has asked, if the patient has an HT catheter or a pump cap, what is the practice in your institution? Whether you use the same catheter for the central venous access, or you will put in another one?
No, so if we could not find the CVP routine, then that hemodialysis catheter we may use. But if we can put a CVP line extra than that, then we use that CVP line. We don't touch that catheter.
Okay, sir. Sir,
But
and
we could not, because only previously it has been kept on the left side, or some puncture has been done, and if I could not make it available again, then I'd use in 1 or 2 cases that hemodynamic catheter what they put.
yes, sir. Sure, sir. Sir, one more query from the audience. Can we use mefentermine for hypertension if not NORAD for the shorter duration during induction?
Yes, we can utilize the MAF in the diluted version. That's not an issue if NORAD is not available.
And Dr. Varun has asked about the morphine dose in CKD patients since metabolites are renally excreted. But I think that has already been
That is
discussed.
already covered by the weapons. So yeah.
Yes, I said, I think I hope that's all for the queries today. Anything else? Audience, can you?
Yeah, one question by
Yes.
Dr. Rajiv Pradhan sir, what are the different causes of the CRS in this young patient? That is already covered by the Dr. Ayushi in her slides.
Yes, all yes. Dr. Muthukumar Rajagopal has asked, sir, they have encountered IJV narrowing in patients with previous dialysis catheter. What alternative is used if there is a difficulty in IJV?
Usually we put a subclavian vein. If we find any problem with the IJV, then I usually keep a subclavian vein. Even hemodialysis catheter I had kept in the subclavian vein. Last time both the IJV was not available or puncture was done before, and the one local wound was not good. So we were not able to puncture IJV. So I had kept that dialysis catheter on the right side subclavian vein.
Bipin sir, shall I add something additional also?
Yeah, sir.
Yes, sir.
Definitely.
So whenever such patients comes to you, basically those on the dialysis for multiple times or chronic dialysis, usually their femorals are gone.
Yeah.
Sides, and you may not be able to find. And at that time, the help of the anesthesiologist is sought. That we want a central line. And I think if you're going to put IJV, it will become more, discomforting for the patient also to carry it, because it is not for just one time. I think maybe requiring for certain things also. Then I have to maintain it also. You have to heparinize it also. So many things are concerned with IJV. But when you put subclavian, it stays for a longer time. You can use it, and there are chances of getting that what you call that fibrosis. This definitely the endothelial injury causes the narrowing of the vessels. So, in chances of injury in the subclavian is much less as compared to the IJV. IJV is a direct, shear stress of the hemodynamic stress, the turbulence of the blood flow, and everything, because the way it goes to the this one right atrium, some valvular lesion is there. Again, you are going to cause a direct endothelial injury or anything, because somewhere when you are putting the line, you always touch some part of the endothelium. So
Yeah,
it's all comforting for the patient to go for the subclavian.
to put a subclavian is little bit difficult, but once you get it, then it is a patient friendly to maintenance is, and we can maintain it for a very long time. IJV so many times it will be for a less, because within 1 or 2 weeks at the end we may get some wound or some infection or something that. But subclavian is a very good place to maintain the.
Sir, cosmetically also, if the patient wants to move
Yeah.
into society, you can still cover it with the shirt and with the even with the clothes also. IJV is very difficult to hide the things also.
Hide
That
the-
is very very important part.
Yeah.
Yeah, Dr. Panna wants to ask something.
Yes, sir. Good evening, sir. I want to congratulate Ayushi. Very nice presentation. And so I just wanted to make a comment that in these patients who already have an HD cath, it's very important to scan the IJV with USG machine. Also, if they earlier had HD cath 2-3 times, then it's very important, because we've recently had few patients, who had history of thrombosis of IJV. So before putting a central line, it's very important to scan the vessels. Secondly, I would like to ask, how often do you do ABG? I think they had mentioned that routinely they don't put arterial line, but do you do an ABG before reversal of the recipient?
After grafting, we do ABG once or twice. But if patient is very well, if hemodynamics is maintained, no cardiac problem, then we don't do too much ABG. If urine output is good, our clinical criteria is stable, then we don't do too much. Twice or thrice in a day, first day, or on the
Sir,
second.
intra-op, I'm asking. Intra-op.
Once or twice, if anything goes according to our plan and if everything is fine, then we don't do too much ABG, because we don't keep arterial line here.
Yes.
Patient
So
is, and we, but
yeah, sorry to interrupt you. Yeah, sir. Go ahead, sir.
so intraoperatively we don't do too much.
Okay. So here also I would like to share an experience where twice I had a patient, a recipient, where the patient was dialyzed the previous day. So that's the usual practice in our institute. So we dialyze within 24 hours. So patient was dialyzed the previous day, And intraoperatively, before reversal, for some reason, I did ABG. And for one patient, I had done it intraoperatively, and one patient before the reversal. And both the times, the potassium was extremely high, and I had to treat it and get it down with GI drip. And since then, I've made it a protocol that even if the patient is dialyzed the previous day, at least, you know, even if everything is fine, I just do one ABG or a VBG just to see the potassium. So, yeah.
Dr. Panna, I will
Yes.
ask the question to you now.
Yes, sir.
You are doing the ABG for potassium only. Is it not recommended? Because I'm telling you now what happens. Invariably, when you are doing the arterial line or a VBG line, ABG or VBG,
Hmm.
the cell lysis, the chances of cell lysis is very high, and that
Yes.
causes the pseudo hyperkalemia also. The more
Yes.
important is the how much that impact of that hyperkalemia is on the hemodynamics, on the ECG, and on the monitors. That has
Hmm.
to be taken into account, and you have to correlate it with before going for the treatment of such a high potassium treatment. If the
Hmm.
patient is stable, the ECG markings are good, everything fine. I don't think so. We should be treating. Rather, the technique of measuring and just for the sake of potassium estimation is not, indicated. And when the center is already doing so many transplantation, I think over the time, they also have come to know that how much and how many investigations are really important, what is really going to be effective in these patients. I
Hmm.
think that also depends upon center to center with a high load. Sometimes what Dr. Bipin said, the baseline ABG is good enough rather than going for the serial ABG in these patients when they know that these are not going to give us much information or much changes, provided the hemodynamic stability is maintained during these procedures. So I think it also depends upon the protocols and the comfort level of anesthesiologists and their skills and experience also. That's, I
Yes.
think, is very, very important part in these patients.
Yes, sir. Generally, see, when we do it, that time, generally, I only collect it. So there's, and plus we have ISTAT machine in each theater. So, and twice it happened that even the repeat sample, the potassium was very high. And all these CKD patients, they are used to high potassium levels. So even if the potassium is 6.5 or 7, sometimes you don't get the ECG changes on the monitor. And generally, the nephrologists are also there in the OT when the transplant is going on. So, like, it happened that the repeat sample also was high. And since then, like, I felt that it is important to do, even
So
though they
you
are
have answered
dialyzed
it
before.
yourself. You have answered it yourself.
Yeah.
Patients have got a very high threshold for the
Yes.
hyperkalemia because they're invariably, and that the most important part is the intravascular as well intracellular potassium levels. The dynamism has to be maintained between the both the electrolytes, how the movement is occurring, because
Hmm.
what anesthesia drug, what anesthesia stress, surgical stress is causing the extracellular movement of the potassium, making it a little bit of a pseudo hyperkalemia that is maybe causing some effect. So I think that may be the reason. And also, if the hemodynamic stability, the ECG changes, the cardiac tissue is not that irritable. I think you are doing it because you feel more safe in doing that. So there is no harm in doing those things. But as a general message, what we think that we should be restricting to the protocols which are well defined for a particular procedure. And if you feel appropriate, the cost effectiveness is not, the matter or whatever it is. I think you can go for it. There is no harm in doing the thing. But as a general measure, I think we should go to the basic defined protocols that one baseline ABG is good enough. And if you require that certain things are going haywire or certain, you are saying that discrepancy in the hemodynamic stability or something, you definitely go for it. I think that is required. So that is
Yeah,
a,
so earlier, so many times I was not doing ABG, but now I have started doing at least one. That's what I
I
wanted.
suggest you combine the, this data and present as a case series. That is going to be a very good presentation and public.
Yes, I published this paper also, sir.
But
Thank you. Thank
I
you.
would like to have one question that
Yes, sir.
with that high potassium, have you
Hmm.
faced problem with that wide QRS or like ventricular rhythms or any changes in the hemodynamics?
No, the potassium was 7, which was very alarming. So 6.5, 7, repeat was 7.2. So at 7, of course, we were not very comfortable, not treating it. So that's why it was treated.
But
And then gradually it came down.
yeah,
So
but
it was, yeah, with GI drip. So definitely, it was high. Because then after 1 hour or 1.5 hours, then it came down to 5.8. So I had presented this paper as well. Thank you, sir. Thank you.
Nimisha, any other question?
No, sir, I hope that's all for queries today. Yes, sir, that's all. That most of the queries have been answered, sir.
Right, Dr. Madhuri, she has raised hands, you have to see.
Madhuri ma'am has.
Yeah, Dr. Madhuri.
Yeah.
This is just after the birthday. She celebrated her birthday. Now she's asking the question. Great.
No, nothing difficult. Dr. Ayushi, excellent presentation by you and both madam and sir. Just one question. You know that your patient of CRF often has to undergo procedures under local anesthesia. Which
Yes,
procedures? Example?
like AV fistula, like in our case, we
Creation
had
of
AV.
AV fistula or
Yes.
what
Um,
else?
Even like before giving epidural, we give local. Apart from that,
Yeah, or even maybe
even
just
HD line when they put pre-op, like for dialysis if needed.
yes, or maybe just a simple dental procedure, or the patient may be posted with a fracture. No, they have osteoporosis, so they can
Yes,
come with a fracture. So very often
yes,
in the exams, you can get a case of chronic renal failure, which is kept for practical exams, and the examiner makes the patient it says that the patient has a fracture and is posted for upper limb fracture and is posted for reduction, open reduction, internal fixation. Okay, so
yes,
it is not necessary that the patient should be posted for renal transplant only. So you
yes, ma'am.
should
Yes,
think on those lines also.
definitely,
Okay,
ma'am.
so that is how the
Yes,
viva goes. Now you tell me,
yes.
suppose, Riga, what is the, tell me something about local anesthetics in a patient of chronic renal failure, like. Tell me about the pharmacokinetics and all, like, is it the same
What
as
is
in a
required for
normal
Dr. Madhuri?
patient?
Tell first, ask her why it is required a local anesthetics. What for?
She told, na? She told. Creation of AV fistula, and if the patient is
Acha
posted for a
creation.
fracture. Yeah.
So,
Hmm.
ma'am, so the dose required will be less
Mhm.
compared to a normal
Why?
individual.
Are you sure the dose required will be less? If you go into the
Yes.
pharmacokinetics, you have to
Rather,
start from what? The absorption,
yeah,
distribution, metabolism,
metabolism
and
and excretion.
elimination. So what
Yes,
happens to the absorption of local anesthetic? Now, suppose you're creating an AV fistula, you have to
yes, ma'am.
inject the local anesthetic, right? So you can give it how? You can give a local block or you can give a brachial plexus block. So now what happens to the
Yes.
absorption? Absorption of the anesthetic, local absorption. Will it
So,
be the same as in a normal person?
no,
See,
like the
absorption.
absorption.
Tell.
So, absorption is like due to protein binding. I don't think
No,
that
no.
is there.
Protein binding, that will be related to the distribution.
Distributed.
Okay.
So it will be
Now,
fast,
yes, it
faster,
will be increased. Why?
increased.
Because of the hyperdynamic circulation.
Hyperdynamic
So
circulation,
the
the
absorption
absorption
will
of
be
local
increased.
anesthetics will be increased.
So
Yes.
what happens is the peak plasma concentration will be high
Higher,
and
yes.
rapid increase in the concentration. Okay.
Yes.
So, and what about the metabolism? As you said, the metabolism, the clearance of metabolites is going to come down. So you're
Calm
going to
down.
prefer which type of local anesthetics in these cases? Amide or
Short,
estetic?
short acting.
Amide type.
Amide type.
Short acting, yes, but amide type.
Amide type.
Means
Yes.
which ones? The usual ones, lignocaine,
Lignocaine
bupivacaine,
and
levobupivacaine, ropivacaine, all those you will prefer. Okay,
yes.
and is there the increased risk of local anesthetic systemic toxicity and all?
Yes, since the clearance is less, so due to
No, there
that,
is not
it may-
much risk. In fact, nothing has been reported on that.
Why the
There
risk
is
should be
not.
there? First of all, Ayushi, see,
Hmm.
whether it's
if
absorption
we are
mechanism or
overdosing.
whatever it is, till it is injected intravascularly deliberately by you, you will not be able to cause a toxicity. And moreover,
Right.
whatever the local anesthetics you are injecting, the dose is a single dose you are using basically for fistula formation. You are not using a continuous infusion or multiple doses. So
Hmm.
one single dose is not going to affect much,
Yes, yes.
provided your liver is good enough to metabolize. And the most important part is the active metabolites of these local anesthetics, which are important. So elimination factor from the renal tissue is also not going to contribute much for this thing. So
Yeah.
that's why I was a little bit skeptical कि why local anesthetics has a much higher role if they are used for a single dose. In
Only
this,
if there is acidosis or hypercarbia in such a case, the patient of
then
CRS.
that
Severe
patient will
CRS.
never come for the fistula formation. He will go for the
No,
hemodialysis.
if he has come for some other kind of surgery then.
He will
Huh?
never come for these things.
Hmm.
And one thing written, I think for a PG, it is a very important. Arterial line is a must, and the CVP assessment. The fluid assessment in this patient is a not good option from the CVP line, the fluid assessment, because already the renal mechanisms are compromised. So vascular status from the CVP is not an ideal, method of fluid. This one. Optimization assessment. So it's always the better to put an arterial line that is recommended when the patient is undergoing transplantation. Arterial line is a must so that beat to beat variation and the volume status you get from the arterial, fluctuations. That is important. So that is a message for all the PG students also.
Right, sir.
Anything else is left? Something?
Good presentation, Ayushi.
Thank you, ma'am.
I see very good presentation and thank you. Thank you, Bajwa.
Thank you.
Thank you,
Thank you.
Bacha sir.
Thank you, sir.
एक मिनट इतनी जल्दी थैंक यू नहीं बोलते होते कुछ और भी करना होता है सेरेमनी होती है जीसी मेंबर हो आप डॉक्टर हिना so my screen is visible to everyone.
Yes, sir. Visible, visible.
Yeah, so from the ESA national side, it's our privilege that we are honored to honor Dr. Bipin Shah and his team. So, sir, it is a very good class. I really congratulate. And because yesterday she was with me, Dr. Hina, she reached at, I think, at 11 o'clock, she reached
Yes.
back to Ahmedabad, and the
Yeah.
morning she is doing the class with you. And so you
Yes,
have
sir.
maintained your team in a good stead. So congratulations, sir, for being the leader of this team. Thank you very much for appearing this class, sir.
Thank you. Thank you.
As
Thank
and
you, sir.
so
Thank you,
Dr.
sir.
Hina, to what to say? She was there doing all the activities in the walkathon and in the that what you call that module and other workshops. She was there till evening, reached late, and she is still here, smiling fresh and doing the class. It's a
Thank
good
you, sir.
the GC members, the presenting the academic classes in the PG forum. That's I think wonderful achievement. So thank
Thank
you,
you,
Dr.
sir.
Hina, for being a
Thank
good
you, sir.
teacher.
Thank you, sir. Thank you.
And
Thank you, sir.
everybody has congratulated Ayushi. Hasn't said a single word till now because the reason being very simple. Uh, her level of confidence is remarkable. I've seen the PG student presenting the classes for the last almost 2 years. The what confidence was oozing from her side was remarkable. Only seen in two, three people till date. So she has done a wonderful job that I can scale, like I can, give a scoring pattern to her also based on my experiences with all the PG students of India. So, Ayushi, so that is the right word for praise from my side. It was a
Thank
well.
you, sir. Thank you so much. It is all because that I have been the part of the transplant team because of sir and ma'am, and we have done the cases. And like ma'am had mentioned before about bilateral renal artery Doppler, I forgot to mention in the slide, but we always write it in sorry, not renal, carotid IJV Doppler. We always do it. And we do it under USD guidance. So that was another point which I forgot to add in the slide, but we do it routinely. And I also got to learn a lot. And just I have come to third year and it was a major case presentation. So it definitely helped me. And I definitely know where I'm lacking. So it will help me prepare. And I hope whoever has heard this, it will help them to listen to the questions. Ma'am, sir, and everyone asked such good questions. So all ISA classes, they help us a lot. Even before this, I listened to a lot of other lectures to understand how to present it. So thank you so much for the opportunity. Thank you, sir. Thank you, ma'am. Thank you, everyone. Thanks a lot.
Good, Ayushi. The classes, they are good boon for all our young anesthesiologists appearing for the examination and for others also in the clinical and daily routine work. They are being viewed on the YouTube because they get permanently recorded. And ISA National is providing these classes free to everyone, anytime, anywhere. When your leisure time, you can attend, you can see, you can watch these recording of these classes. Wherever a doubt, I think this is going to be a huge factor in the enhancing the patient safety. So that's why the classes are meant for. So good. If you keep it up, and I think you will be doing a good job in examinations also.
Thank you, sir.
And then Nimisha, she's another dynamic youngster. She handled this stage very well in asking the questions and doing all the thing. And they got a training of 30 minutes. In 30 minutes, she learned everything and she presented. So congratulations, Nimisha, for carrying such a good screen moderation today.
Thank you so much, sir. Thank you, sir, for the opportunity also, sir. Thank you so much, sir.
And as always, usual, Dr. Madhuri, she has always turned off her screen when I always congratulate her for conducting the class. She always turn her screen off. She doesn't want to listen the praise. So that's why. And Dr. Riddhima, they both are the class coordinators for a long, long time. And I think the training of the trainers, they are the training of the trainers of the trainers. So it's a good that they are coordinating with the ISN National for conducting these classes. And these classes are I think boon for our ISM members wherever they are and in whichever year they are studying out, I think. So anybody wants to suggest or give an opinion, they can unmute themselves and they can give it the moment. Anybody wants. Besides already who have conveyed, anybody else wants to give opinion or any question or suggestion? We will not be asking the counter question, that's for sure. You can ask or suggest anything. अतुल गांधी जी, सर जी, आप तो बोलिए, गुजरात के सेक्रेटरी हो, मिस किया आपको कल? अनम्यूट करिए, अनम्यूट.
Sorry, first of all, sir, congratulations in our Gujarat team also. And this IOC's presentation, Dr. Bipin Shah, Dr. Hina Shah, they are doing very hard work. I am sorry for our yesterday event in Surat, because I already booked in my VVIP booking in the Tirupati Darshan. You saw my face. I already give my hairs to the Tirupati Mandir. So it's a very planned occasion, and it's a very difficult to get this VIP darshan. That's why I'm sorry for that, because I'm not attending the Surat conference.
Anyway,
Yeah.
you were the loser actually. It was a very well conducted program.
Yes, sir. Yeah, it's very, very superb. I was totally coordinated. Is a walkathon is very absolutely very superb, great. And also the all the program in the workshop, Sunday workshop is very nice.
We missed you, sir.
Yeah. Thank you. And we are again in 16 January again our CME, and also the 2nd February our CME. In March, April we are doing Gujarat State regularly workshop since 6 months we are planned according this every month 1 month we can go for the one CME or workshop.
I know under your leadership everything is going very fine. I think you keep up the momentum.
Yeah.
Dr. Dhruva Savani is also smiling. She wants to say something. Madam,
Yeah.
please.
First of all, thank you. Atul sir has went for darshan at Tirupati and he must have prayed there for us.
Yes. Yes.
And that was the reason for super show yesterday. Let's defend him actually.
So you have given all credit to Dr. Atul for the good
No,
show.
it's a teamwork. It's Surat teamwork, sir.
I don't
100% sure. She's very so the Dhruva and all part they are doing excellent work.
Yeah,
And
yeah,
this
it was
month
very
they are
good.
doing
Dr.
very hard.
Dhruva, Dr. Rajiv, Dr. Dharia, and all the
That is-
people, everybody contributed. I think the academics require this thing, and PG students were also there.
Yes, sir.
So it was a very good, blender of academics yesterday. And today also the class in the next day, just like you have a Diwali, you have a next day another Diwali
Yes.
doing all the hard work, and your class has been presented.
Yes, sir.
Yes, sir.
So Dr. Sadiq is also writing something. These sessions are really motivating. And what else? Thank you everyone, Sadiq. Acha. And these stressful phases of MD final exam preparation plus time are great. I think it is for every. Dr. Rekha ma'am, आप भी कर लो, unmute करो पहले. Rekha ma'am,
Good
अब आप.
evening, sir.
Good evening, ma'am.
Good evening, sir.
Good evening.
So this was a very nice presentation and very good efforts were seen from IUC as well as Hina madam and Bipin sir. And sir, every Monday these classes are going on. These classes are very useful to not only for PGs but for us also. Even while teaching students and before going for the teaching class, we used to learn something from these classes. So thank you very much, sir.
Yeah, and this is a fact actually. These classes have contributed, and it has almost united almost every PG to a common platform. So ISA classes have become a very, very, good uh, means for them to prepare for the examination, which they anticipate the question.
Yes,
I think another person is there on the line. He want to speak something. Mission one, you want to say something?
Sir, amazing. I mean, I just feel that why I was born 30 years before. During our time, we never had this type of secretary, this type of functioning of ISA. I congratulate you, sir, and I congratulate the young Dr. Ayushi for her excellent presentation. Of course, her mentors, both Madam Hina and Bipin, sir. I'm so happy that I have attended this, and I have also learned so many things because in our center we have recently started renal transplant, sir. We have done 13 cases very recently. We got the certification from government, and so this is going to be a. I have asked all my team to join this, and I'm sure that they will be very happy listening to this wonderful presentation. Thanks once again, sir. Long live ISA, sir.
Thank you, Dr. Rajiv. And I think these wherever the regional transplantations are going to come up, I think many places accreditation has to be done based on these classes. You can get to know many things which you sometimes miss, which sometimes may not come to the mind. I think another one or two class in another 1 year, everything will be perfect in the renal transplant thing. So all the questions are covered. Dr. Ashish Devan also want to say something. He has raised his hand. Sir, I've seen your hand. Don't worry, please, sir.
Good evening.
Good evening.
First of all, congratulations to IOC and the whole GCS team. And we must thank Dr. Bajwa for giving this opportunity to Gujarat after some time. Really, this is a wonderful program for the postgraduate students. And the way in which Dr. Madhuri asked the questions and led to the kind of a Viva MOOC, I think that was great. And whenever I was a PG teacher, I'm no more a PG teacher now, but I was training my residents how to lead the examiner to what you want to answer. So this is a great training for every PGs, and they all will come at the national platform, and wonderful programs are going on. Bajwa, I think we must thank you first. And yesterday and two days back program in Surat, probably we have a multifaceted persons, but this was a multifaceted program. Everything was hit. And probably, Bajwa, I'm not flattering you, but you stole all the shows, all the three events.
Yeah. Yes, 100%. 100%.
Yes.
Yeah,
No question.
100%.
Thank you, sir. Thank you, sir.
So much.
Thank you, sir. Dr. Dhruva madam again want to say something.
जी एक बहुत बड़ा थैंक यू बोलना था. मैं पर्सनल फोन करूंगी उसके लिए. और सर प्रैक्टिशनर मॉड्यूल के लिए एक सजेशन भी था जो मुझे अच्छा लगा, वो भी बोलना था. एक सजेशन ये कि हम जो डिलीवर करना चाहते हैं डेलीगेट्स को, तो कल मैंने ये नोटिस किया कि डिस्कशन कभी कभी रॉन्ग ट्रैक पे चला जाता था. पर्सपेक्टिव अगर हम पहले से बोल देंगे उनको, देन सच में उन लोग थोड़ा प्रिपेयर होके आएंगे कि हमें अलग नहीं सोचना है, हमें इसी डायरेक्शन में सोचना है टुवर्ड सॉल्यूशंस, जो एक्चुअली हमारा मोटिव था. तो ऐसा हम इन फ्यूचर कर सकते हैं क्या?
Ma'am, to be very frank, what my main idea from the module is, let all the negative things also come.
अच्छा, okay.
No, you have to neutralize those negative things to make the solution positive, to take it further to the module, to the decision making. Ma'am, sometimes what happens, even in the negative points, you will come to know a very, very positive point which you can incorporate into that decision making. So वो इसलिए essential होता है because yesterday time was less. Otherwise, we could have gone for further discussion also on those things. In the end, ma'am, see, when we are there, Dr. Myself, Dr. Manisha, Dr. Madhuri, Dr. Indrani, we all are working very hard for this module. In the end, the message goes very clear. The message is very clear what we want to give, but it's always pertinent to listen to everyone, ma'am. It's not that everything is positive. Negative, you have to take into stride because majority of the practitioners of our country are facing the negative things also when they are giving anesthesia. So those things also have to be taken into account while arriving at a positive decision. Similarly, the PG student also now in these classes, they come across some negativity during these, the period, the course also. So those are very, very essential to make you a more polished person. If you see all everything a positive or a one-way track, na, you may not be able to improve or you may not be able to enhance your communication, learning skills. So negative is a part of life. So those things have to be learned, ma'am.
No. I'm not telling that. Delegates को ये बताया जाए कि हमें सामने वाले ने क्या गलती की, उससे ज्यादा अभी ये गलती हुई है तो करेक्शन के साइड पे कैसे सोचा जाए, उस पे ज्यादा फोकस दे सके अगर तो।
मैडम, मैं तो ये कहना चाहता हूँ कि इट वाज अ वेरी वेरी गुड डिस्कशन कि पीपल वर वेरी एक्टिवली पार्टिसिपेटिंग. That was the more important. You participate in a discussion, that's the most fruitful thing. बाकी जो होता है ना मैम, देखो ऐसा है, when you are having the program direction, so you can always know what to be taken into the take home message. That is very, very important, what to be given in the final thing. Similarly, in the PG classes now, so ultimately what was there in any renal transplant cases, they have to be done in a very high center. You can't do in the smaller center. These are the high centers, specialized centers, and you have to have the all the equipment for measuring your this one hemodynamics, whether it's arterial or something, or you have to have other monitors, advanced monitor also. And if it's a blessing, if you have got an ultrasound also for putting the lines or putting something else, that is very, very important. So ये message जाना बहुत जरूरी है PG students का, क्योंकि they will be appearing for the examination and everything has to be the topmost while they are answering the theory or practical part during the exam.
One or 2 point.
Yes, ma'am.
जी.
Your voice was not audible properly.
अच्छा, नहीं, मैं ये बोल रही हूँ सर कि मैं ऑलमोस्ट 70-80% पीजी असेंबली मैंने अटेंड की है और हर असेंबली के बाद एक आधा पॉइंट ऐसा मुझे मिलता ही है दैट मैं जानती शायद हूँ, बट आई वॉज नॉट एम्फेसाइजिंग टू डू सो. तो इट पॉलिशेस इवन सीनियर पीपल्स प्रैक्टिस ऑल्सो.
Yeah, fine. Well taken, point well taken. We will keep this thing also in our mind. And now I'll welcome that as a president, you should appoint 4 or 5 people from a Surat City branch as a faculty for this module. You just send me the name so that we can have them in our faculty list. So whenever we are doing in Gujarat, they can come also to be part of as a faculty there.
Sure, sir. Sure. Thank you.
So I think anything else from Dr. Madhuri and Dr. Ridhima before we wind up? These are our class coordinators. They are super class coordinators, untiring, non-retiring. Yeah, Dr. Madhuri.
I would like to congratulate Dr. Nimisha. She just managed the thing alone as the screen coordinator. Very good pickup. And the entire team was really amazing.
Yeah.
Thank you, ma'am. Thank you so much, ma'am.
Nimisha, she had a very good attitude. She will go a long way in the further becoming a good faculty for IS and National also. You can, Nimisha, get ready for that, for the wings we have already. Dr. Ridhima, you want to say something?
Yes, sir. I think I will definitely want to congratulate Ayushi for wonderful class and Hina ma'am and Vipin sir. And Nimisha, as madam said, she has picked up everything in 30 minutes. And I think as far as the class is concerned, we have discussed everything and no stone has turned unturned to, decode anything. I think everyone you have exposed the Viva. Madhuri ma'am has given so good questions. So Ayushi, as sir always said, Ayushi, you will pass if this long case will come to you. We will talk. I'm sure about it.
My questions were just to make you, to
Ready.
tame you how
Ready.
to face the exams. That's all.
No, it's
So Dr.
it's
Madhuri
good,
will be an
ma'am.
external examiner. She will be external examination, I'm sure.
Okay.
Dr. Hina will be calling Dr.
Yeah,
Madhuri
yeah,
to the external
yeah.
examination.
Sure, sir. We'll try our best to bring the Madhuri ma'am at the Ahmedabad PG exam, sir.
I think it's time to wind up now. We'll be meeting in the next class.
Yes, sir.
So every time we leave, we always say,
Jai IC.
long live ISA.
Long live ISA.
ISA.
Long live ISA.